Hello everyone, I am Dr. Wajid Shabir with another video on ECG. Today we are going to discuss the 50th case in this ECG case series videos. This is the ECG which we are going to discuss today, but before starting the discussion on this ECG, as always I would like you to pause your video. Note down the findings and diagnosis with yourself, and at the end of the video compare your findings and diagnosis with what was discussed in this video. So let's begin the discussion on this ECG. As you know from our previous videos that the first thing which we look at on an ECG is rhythm. For rhythm we look at the rhythm strip, which is a long lead at the bottom of the ECG. As you can see, this is a long lead which is lead to our rhythm strip. For rhythm to be sinus, there should be prominent upright P waves before each QRS complex. Here we can find that there are upright P waves before each QRS complex, but these P waves are not that prominent as they are in normal ECG. Whereas in V1 we can find prominent upright P waves before each QRS complex. Here you can see that there are upright and prominent P waves in lead V1. Normally in lead V1 the P waves are not upright, because in a normal heart the direction of heart vector is away from lead V1, which is located on the second intercostal space on right side. So the presence of upright P wave in lead V1 means that the rhythm in this case may not be originating from SA node. And now moving on to the heart rate. For heart rate we will select a QRS complex which lies on a broad vertical line, just like this QRS complex, and between this QRS complex and next QRS complex we will calculate the large boxes as 300, 150, 100 and 75. So the heart rate in this case is 75 beats per minute. Next we will look at the axis. For axis, as you know, we look at lead 1 and lead AVF. In lead 1 you can see that the QRS complex is isoelectric, meaning that the amplitude of R wave is equal to S wave. Similarly, in lead AVF, the QRS complex is isoelectric. So in this case, the axis is indeterminate. Next thing which we look at on an ECG is PR interval. As you can see that the PR interval is prolonged in this ECG. It is prolonged and fixed. Similarly, the QRS complex in this ECG is within normal limits, that is, it is less than 3 small squares or 120 milliseconds. However, in lead V1 you can note that there is RSR pattern. So presence of narrow QRS complex with RSR pattern in lead V1 is called partial right bundle branch block. Now after the R wave we look at ST segments, but here in this case we can note a hump within the ST segment. You can see that after QRS complex there is a hump in ST segment. This hump is similar in morphology to this atrial activity which is before QRS complex. And this atrial activity, which we will call as atrial tachycardia, because the rate is more than 100 and it is being conducted in 2:1 fashion. So we can say that this is an atrial tachycardia with 2:1 AV conduction. Next is ST segment. The rest of ST segment does not show any ST elevation or ST depression. Also we can see that the QT interval is within normal limits. So to sum up the findings, this is atrial tachycardia with 2:1 AV block. The axis in this case is indeterminate. Also there is partial right bundle branch block. So this is all for today. Hopefully you like the video. For more videos, kindly subscribe to this channel and stay tuned. Thank you and Allah Hafiz till next video.